The views and opinions expressed by speakers and or other third parties in the BGLC digital programming series do not necessarily reflect those of the BGLC partners. This webinar series is provided for general information purposes only and does not constitute legal or professional advice. No user should act on the basis of any material contained in the webinar without obtaining proper legal or professional advice specific to their situation. The pre-activity assessment is given to attendees or participants of CPGI activities to establish baseline understanding of research in the All of Us program. The assessment takes individuals approximately 2 minutes to complete. So take out your cell phones and scan the QR code to save time and effort, or click the link. Please access the survey and complete it now. Again, this survey is very critical for us to obtain baseline information. So please complete the survey. Again, use your cell phones, open your camera and scan it and access the QR code, and then can access the survey and complete the very short questions. Thank you again. Welcome to Prostate Cancer Awareness Webinar. I'm Eric Webb, Social Media Coordinator for Alpha Phi Alpha's BGLC team. And on behalf of the All of Us Research Program and Xi Tau Lambda chapter of Alpha Phi Alpha Fraternity Incorporated, we welcome you. Please watch this short video.
What lies inside all of us is more than data, it's life. What's flowing through America's veins is its diversity. And it's those very differences that will lead to answers for generations to come.
The All of Us Research Program, there's a gap in medical research that only you can fill. Health research. Health research is the process of finding out new things about improving people's health. The first step to understand the concept of health research is the process of finding out new things. Health research is the process of finding out new things about improving people's health care. Did you know that the majority of health research has been conducted with middle-aged Caucasian men as their participants? That means that the medicine or treatment resulting from that medical research is designed specifically for that demographic. Communities who are underrepresented in medical research then are at risk of experiencing negative responses because it's not best for their body. Going forward, we need to do a better job of including all types of people in health research. The only way we can fix this injustice is with your help. So, what is the All of Us Research Program? The All of Us Research Program is led by the National Institutes of Health that's working to improve healthcare through research. Unlike research studies that focus on one disease or a group of people, All of Us is building a diverse data set that can inform thousands of studies on a variety of health conditions. It is a longitudinal effort to gather data from 1 million or more people living in the United States to accelerate research and improve health by taking into account individual differences in lifestyle, environment, and biological makeup. All of Us is the largest and most inclusive of of research programs ever. Precision medicine is healthcare that is based on each person. Precision medicine takes account 3 factors. So we're all different, right? But when we go to the doctor, our treatments are often the same. Your healthcare and treatment should be tailored for you. This is called precision medicine. Precision medicine is a new approach to improving health, treating disease, and finding cures. It acknowledges that a one-size-fits-all approach to medicine isn't the best, because we know that what works to treat me may not work to treat you. Each person is different. Factors that greatly impact our health are our genetics, our lifestyle, and our environment. Ultimately, precision medicine can produce more accurate diagnoses, earlier detection, and better prevention strategies and treatment choices. Now, here's some examples of precision medicine. Prescription eyeglasses, what we're most all familiar with, blood transfusions, insulin pumps, and hearing aids. So, what are social determinants of health? A growing body of research shows that centuries of racism in the United States has had a profound and negative impact on communities of color. The impact is pervasive and deeply embedded in our society, affecting where one lives, learns, works, worships, and plays, and creating inequities in access to a range of social and economic benefits, such as housing, education, wealth, and employment. These conditions, often referred to as social determinants of health, are key drivers of health inequities within communities of color, placing those within these communities and populations at greater risk for poor health outcomes. And that's from the CDC. So you want to know more about information or how to enroll? Well, visit the All of Us website at joinallofus.org/together. There, you can learn more about the program or choose to sign up if you are ready today. Or you can download the All of Us Research app in the Google Play or Apple App Store. Now, you may notice there are 2, and I said 2, All of Us apps in your app store. Please be sure to download the one that's named All of Us Research with the all-white background created by Care Evolution. Note, the All of Us app can be downloaded on your computer, phone, iPad, tablet, or any other digital device. So, once you to enroll and the next steps. So it's pretty basic. Once you've created your account, you will be asked to give your consent. This includes reviewing a series of videos which will provide more detailed information about the program. These describe all the types of information you may be asked to give. Once you feel comfortable that you know what to expect, and if you are ready to give your consent, you electronically sign the consent form. Now, you can do all this from your computer, tablet, or smartphone, or a partner center. Now, you may also elect to share your information, your electronic health records, which is a digital version of your medical chart, and complete the consent to get the DNA results. You will then be asked to answer several health surveys in combination with other health information. The answers provided in these surveys can help researchers identify patterns about our lifestyle and background affect our health. After these initial steps, you may be asked to share your physical measurements and provide your biological samples so that the program can help researchers better understand how different factors, including genetics, make our participants unique. Now, go to the site and locate the Join Now button to create your account, or know where to come back to when you are ready to become a partner. MSRS, the Minority Student Research Symposium, and with the All of Us Research Program, invited underrepresented minorities, URMs, to complete a research project using data from the All of Us Research Hub and present their work in a virtual poster session on Saturday, May 22nd, 2021. Greater participation of all racial and ethnic groups is needed in biomedical research. URMs represent over 30% of the US population, but less than 9% of STEM PhD members and 7% of all physicians. We know that diversification of the medical workforce will help address the critical need the US faces to reduce racial and ethnic health and healthcare disparities. Now, welcome. Again, welcome. Next I'd like to introduce our moderator. Brother Arthur L. Gregg is the owner and CEO of Gregg Training and Consulting, LLC, located in the Dallas-Fort Worth Metroplex. He is the All of Us Research Program Coordinator for Alpha Phi Alpha Fraternity Incorporated and the BGLC. He also serves as the Assistant Vice President for Multicultural Affairs and Director of the Multicultural Center at the University of Texas at Dallas. He is the past president of the Texas Association of Black Personnel in Higher Education and a graduate of Leadership Richardson. Gregg also serves as a lead facilitator for Leadership. He is also one of the creators and serves on the steering committee of the Aiming for the Stars African American Male Academic Bowl, which is in its seventh year. Gregg is also known for his presentations and workshops on topics ranging from leadership and leadership development, diversity, equity, and inclusion, the multicultural workforce, college and leadership development, diversity, equity, and inclusion, readiness, recruiting, and retention of underrepresented minority students. He is an active member of Xi Tau Lambda chapter of Alpha Phi Alpha Fraternity Incorporated. He received his bachelor's degree from the University of Houston and his master's degree from Dallas Baptist University. Please welcome your moderator for tonight, Brother Arthur Gregg. Welcome, Brother Gregg.
Thank you, brother. Thank you. Thank you so much, Brother Webb. And thank you for sharing that information on the All of Us Research Program. Great information and a great program. And I was feeling you when you were talking about those prescription glasses and precision medicine. These are readers that I'm wearing tonight, and I know that my prescription glasses wouldn't fit anybody else because I can see everything clear now. And so, good evening, and on behalf again of Alpha Phi Alpha Fraternity Incorporated, the All of Us Research Program, and the Xi Tau Lambda chapter of Alpha Phi Alpha, we want to welcome you to tonight's program. And we all know that prostate cancer affects all of us, including our families, our friends, relatives, brothers, loved ones. And so tonight you're going to hear from a urologist, a brother who has spent many years in studying and researching prostate cancer, and from a survivor. Oftentimes we hear a lot of information from the doctors on the medical perspective. Today, we want to spend a little time on both the medical and the survivors. So sit back, relax. We definitely want you to put your chat, your questions and comments in the chat. We definitely want to hear from you and engage you in this conversation, because that's what it is. It's a conversation. So let's get started. And first off, I want to introduce you to our physician. Brother Dr. Kevin Moses is Associate Professor of Urology at Vanderbilt University Medical Center and Director of the Comprehensive Prostate Cancer Clinic. He is a Phi Beta Kappa graduate of Morehouse College and received his MD and PhD training at Baylor College of Medicine in Houston, Texas. He completed his urology residency at Emory University, followed by a fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center, where he served as the chief administrative fellow. His clinical practice focuses on advanced prostate cancer, including several clinical trials, as well as surgical management of advanced renal, penile, and testicular cancer. Dr. Moses' research is focused on addressing health disparities in urologic cancers, determining the roles of health literacy and patient interactions with the healthcare system, and optimal care for patients with metastatic and or castrate-resistant prostate cancer. Brother Dr. Moses, welcome.
Thank you so much. Thank you, Brother Greg. Thank you to the Xi Tau Lambda chapter brothers and Alpha Phi Alpha Fraternity Incorporated for inviting me here. What I'll do is kind of give a brief overview of prostate cancer and how it relates to Black men. And towards the end, I believe after we have the presentation from Brother Williams, we can have a question and answer session. So what I want to focus on in prostate cancer in screening, diagnosis, and treatment options. Just to start out, here's where the prostate sits. A lot of men are not quite aware of where it is. It's right in the center of the pelvis. It sits under the bladder. It sits just in front of the rectum. And so that's why those of us who've had their prostate examined, that's why they have to put their finger where they do, because that's the location where you can examine the prostate. As I said, it sits just below the bladder, and actually the urine, as it goes into the urethra, it passes through the prostate. That's why as some of us get older, as that prostate enlarges, it makes that channel narrower, and sometimes it takes a long time to get that urine out. But the function of the prostate is actually to help break down the semen so that you can maintain your fertility. It's relatively small, about 20 grams, the size of a walnut. And as I stated before, as you get older, it does get larger. Now, prostate cancer is the most common solid organ men in the United States, and is actually the second most common cause of cancer death after lung cancer. It is more prevalent and presents at more aggressive stage in Black men. In fact, Black men in the United States have the highest incidence in the world, even compared to our Caribbean brothers and our brothers in West Africa. Additionally, we have greater than 2 times the mortality, 2 times the risk of death from prostate cancer compared to white men in the United States. And much of this is due to Black men less likely receiving screening, which is done by the blood test, the PSA, and the rectal examination, and also less likely to receive treatment for prostate cancer. Now, in regards to screening, several of the guidelines panels have set forth their recommendations. The American Urological Association recommends screening from ages 55 to 69 if you have a normal life expectancy, and have a conversation with your physician about the risks and benefits of screening. They do make an account for Black men and those who have a family history, such as brother, father, or sons, and begin screening at age 40. Additionally, men who are older than 70 and in excellent health may also benefit from screening. The NCCN recommends, again, shared decision-making, discussion between men and their physician, and screening from ages 45 to 75. Men who have a very low PSA can actually have less frequent testing on maybe a biannual or every 3-year basis. And again, for very healthy older men, you can continue screening. Lastly, the United Task Force, which most internists and family medicine physicians follow, they do give it a grade C, meaning it can be recommended after a discussion with their physician for men ages 55 to 69. So the big question is, what is a normal PSA? And there's really not a cutoff for where a PSA where there would be no cancer. And when we're looking at PSA values for a man and is it concerning or not, we have to take into account a man's age, the size of his prostate, and any prior PSA measurements. That's why it's important to get that annual or every other year PSA so that you can track the trend. Importantly, a PSA of 6, you can repeat that number in about 3 to 6 months if it's minimally elevated. Sometimes you do have fluctuations in that number. If there's true evidence of infection from a urine or blood culture, then you would give antibiotics. Otherwise, if it's elevated, you can get an MRI or certainly proceed to getting a prostate biopsy. This is how a biopsy is performed. An ultrasound goes in the bottom, just like when you do the exam. We can take pictures of the prostate using the ultrasound, and we also inject numbing medication around the prostate. It should not be a painful process. And then as you can see on the right here, these are the areas where we would take samples to see if there's any cancer in the prostate. Now this is using an ultrasound. You can also do what's called a fusion biopsy if you get an MRI, where the MRI images are fused with the live ultrasound, and you can target specific areas on your biopsy. Once the biopsy is done, the samples are sent off to the pathologist, and they look on a slide and see what the pattern is. And the more aggressive, the higher the number. You can see here grade 2, 3, 4, 5. Usually there's more than one pattern, and so the two patterns are added together. So if you have some low-grade cancer, grade 3, and some intermediate grade cancer, 4, they will add that together. 3 plus 4 equals 7. And for the vast majority of men, that Gleason number goes from 6, because Gleason 3 plus 3 would be the lowest grade, up to Gleason 10, where Gleason 5 plus 5 throughout the prostate. And once you have all the information, then you can stage and risk stratify patients into low, intermediate, and high risk. And risk means risk of cancer coming back if treated, or also risk of death from prostate cancer. For low risk, you have to have all of the above here: a PSA of less than 10, a Gleason number of 6, and a normal physical exam. For intermediate risk and higher risk, the PSA increases, the Gleason number goes from 7 or 8 to 10, and having an abnormal prostate exam. If you're in the high risk category, you should also get staging imaging with a bone scan and a CAT scan, because prostate cancer does metastasize to the bone as well as lymph nodes or other organs. Regarding options for prostate cancer, for older men who do not have or have limited life expectancy, or those who have several other medical issues, we actually would just watch and wait and see if they ever get symptoms for cancer before providing treatment. On the other end of the spectrum, for men with metastatic disease, meaning it has spread to other organs of the bone, we actually block testosterone production, which is called androgen deprivation, usually with shots that are given every 3 months, or removal of the testicles, or a pill that can be taken daily. Now, for men who have low risk of death from prostate cancer, or very low risk, meaning they have a very small amount of low-grade cancer, you can actually avoid treatment by performing what's called active surveillance, where men get a PSA every 6 months. You repeat the biopsy with an MRI, usually on an annual or biannual basis. And the purpose of this is that if there is escalation of disease, if the Gleason number goes higher or more coarse or positive, you can still get timely curative treatment before it progresses outside of the prostate. Now, when talking about active treatment for prostate, there's two basic versions. One is radiation therapy, which is sometimes given with hormone deprivation. And you can see here listed the various forms of radiation, including implanted radiation seeds, and you can do a combination as above. The imaging that the radiologists get, you can see here a cross-sectional image. What's in red there is where the prostate is. And what you see in blue and green are the areas where, even though the beams are coming in, they target it to that red area so that there's no damage to surrounding structures. And this is a depiction of a man here. This is the type of machine you'd be on if you were getting daily treatments, usually lasting about 5 or 6 weeks. The other sort of large category is surgery or removal of the prostate. And this can be done in an open fashion or minimally invasive fashion, most popularly with a robotic assisted approach. In an open surgery, you have an incision on the lower part of the belly, which you can get into the pelvis to remove the prostate and the lymph nodes within the pelvis. As you can see here, when the prostate is removed, you have to connect the bladder back to the urethra so that it continuity of the urine. In a robotic approach, as you can see in this picture, the surgeon is off to the left looking at a console, which gives you a 3D 10x magnified image, and you're controlling a machine that is attached to the patient through ports that are seen here, and this is the type of view that you would get. The benefit of the robotic approach is you have much more precise anatomic dissection and can help spare critical structures down in the pelvis. There are other treatments available, including cryotherapy, where you freeze the patient, high intensity focused ultrasound, or HIFU, where you raise the temperature and target tumors. And then there are multiple treatments for men who have metastatic disease, or if they have been on hormone therapy for several years and the PSA starts rising, we have options for hormone resistant disease. Now, many men want to know about the different complications of treatment. Importantly, disease recurrence is something you want to avoid, so you have to continue to check PSA after treatment. And if the PSA starts to rise again, which is called biochemical recurrence, you can perform salvage radiation after surgery. You can do surgery after radiation, though it's more difficult. And then there are other medications that can be used to block testosterone production. Another risk is incontinence or leakage of urine. The risk depends on the man's age. The older they are, if they have surgery, the higher the risk of incontinence. It depends on the type of treatment. Surgery, much more likely to cause incontinence compared to radiation. Everybody needs some pads after surgery, but for younger men particularly, they do pelvic exercise and they should get back to total continence or maybe one safety pad. Erectile dysfunction is a big issue, and obviously it's something that's very concerning for men. Again, it depends on men's age and what kind of function they have. Some men might think a little more of what they provide than they actually have. But we do try to spare nerves around the prostate if possible. And then most men will require at least oral medication to help with erectile function. With radiation, most of the symptoms are during treatment, such as urinary frequency or burning or diarrhea. And this typically gets better after treatment stops. Issues with incontinence and erectile dysfunction are less common in radiation and usually more a function of time and age. There is some risk of cancers in the bladder or rectum because they are nearby, and men just need to be screened for those if they have radiation. Fortunately, the vast majority of men who are diagnosed with prostate cancer live with prostate cancer. And therefore, you have to have a good mentality about survivorship. You need to educate yourself, have a healthy diet and vigorous exercise at least 3 to 4 days a week, and take advantage of your support resources like family and friends and some of the cancer advocacy groups that exist. But most importantly, don't be afraid to ask questions. Even though this is a sensitive topic and you're dealing with some of the most personal issues, use reputable resources in order to educate yourself. I'll be available for questions at the end of the presentation.
Awesome. Thank you, brother. I mean, that was some good stuff. I was jotting notes down myself, and we got some really good questions in the chat. So when we come back to the question and answer portion, be ready because they've got some good questions out there, and we're engaging you. Be sure to drop your questions in the chat. I know there are a lot of things that you probably don't know, or if you heard, you want to know. We're here for you, and so. This brother that's coming up next, our survivor, this brother is a brother's brother. And I can't say any much more about him other than the fact that if you wanted to hear from a survivor, a true survivor, someone who has seen and done and been there, you're in the right place. And so at this time, I have the pleasure of introducing our next speaker. Brother Derek Williams is a 6-year prostate cancer survivor. He celebrated, look at this, y'all, his 54th birthday last month by getting his semi-annual checkup and remaining cancer-free. So I'm saying, all brothers out there, on your birthday, get that checkup. He is a tireless advocate for promoting prostate cancer awareness amongst the brotherhood and Black community at large. Diagnosed at 48 years of age, which is on the younger side, defeats the myth that prostate cancer is an old man's disease. Well, I'm glad you said that, Brother Williams. In addition to holding his annual prostate cancer awareness breakfast program in the Dallas-Fort Worth area, he's been asked to attend a variety of church and women's health fairs over the years, setting up his table, handing out prostate cancer brochures, and deepening the knowledge of our community and brotherhood. He finds the one-on-one conversations most valuable, where he can go a little deeper into his journey, becoming the staunch advocate for prostate cancer awareness. Brother Williams is the 2020 Zata Lambda Chapter Brother of the Year and received his 2020 Texas Council of Alpha Chapters, the Harry E. Johnson Humanitarian Award. He was recognized for his distinguished engagement in humane acts, serving to promote brotherhood and social well-being in the ranks of fraternity and community. Brother Williams' motto is, "No brother walks alone, no brother fights alone, no brother suffers alone." Brother Williams, we're glad that you're here tonight, and we're glad that you brought up the fact that this is something that affects not just men but women too, and to see you at the women's conferences and all of that talking about prostate cancer is important. So, Brother Williams, it's on you.
Thank you, Brother Greg. Oh, whew. Well, I'm going to spend some time this evening talking about my journey, and I call it the aftermath. And my journey started 6 years ago. 6 years ago, about this time, or late November 2015. I was life was good. I was due to go in for my normal annual visit to my urologist. Not really thinking anything. I'd been getting screened since I was 40 because there was family history, but very, very routine over the years. And my thought was this would be a very routine office visit with my urologist, Dr. Allen. I go in, I get the blood test, I get the PSA work done, and then I circle back to Dr. Allen's office, and he then performs a DRE, digital rectal exam, and he's filling the prostate, that's the finger, and that has to be done. There's really only one way to get that done, and then we have a conversation like we normally do, and typical doctor-patient banter, and I leave. I go about my day. I think I went back to work. Well, 2 days later, get a call from Dr. Allen's office. Dr. Allen would like to see you to discuss your lab results. And again, I'm just thinking it's not even on radar. Like, it's just not registering that, okay, there could be a concern here. Go in, he has his, lab report there. He's like, Derek, your PSA went from 2.5 to 5. So I'm like, wow. And so we're talking some more, and he's like, look, I gotta, he talked about some options, but he's like, look, this is concerning. You've been pretty consistent. You've always been in that 2.5, low 2 range. I'm 48. My PSA goes from 2.5 to 5. Okay. That's a concern. He's concerned. He's like, look, I want to do a biopsy. And I'm like, okay, look, I'm going to follow your lead. We didn't talk much. We just scheduled the biopsy the following week. I go in and, not really sure what this biopsy was going to entail, but, Dr. Allen tried to explain to me the best, but contrary, for me, it was painful. You're in an examining room, you're exposed, you're in stirrups. There's only one way to get to that prostate. And, it was uncomfortable. So there were 12 samples of my prostate taken out. And at the end of that process, I think I just had to, you got to sit there for like an hour just to make sure you don't pass out. And I can see why. Painful. But Dr. Allen, he got his 12 samples of different areas of prostate and sent it on to the lab. I'm off and running back to work again, like not really thinking anything about this. It's just still not registering. Well, I forgot I had that biopsy done, and I think it was the Friday before Thanksgiving, about 3:00. A cell phone rings, pick it up. I can see it's Dr. Allen's office. I answer. It's a vet who's Dr. Allen's nurse, and we have a great relationship. Like anytime I go to see Dr. Allen, she's great. Like we, first name basis. She hit me with Mr. Williams. Never ever called me Mr. Williams. Oh, I just never ever called me Mr. Williams. Like we've always been first name basis. Like, and we're just cool like that. But she hit me with Mr. Williams, and then hold on, because I couldn't even respond. Dr. Allen, I got to get Dr. Allen's coming on the phone. So I'm like, and then Dr. Allen, he straight to the point. I think very, very, very direct. And he just said, Derek, you have cancer. Okay. All this is just like, I'm just going so quick. To hear your doctor tell you you have cancer. Just in slow motion, just you hear the word. And I just slowly started to drop to my knees with the phone in my hand. I don't really cry a whole lot in my life. At funerals, I'm not a brother that really cries. Bond. Yeah, my wife, at the time she came in, put her arms around me, and I was just, and then something strange happened. Dr. Allen said, I could hear, I was just, a lot of thoughts were going in my mind, but I was mainly just crying. And Dr. Allen said, Derek, hey, we're going to get this after the new year. And mind you, this is, third week, November, whatever. We're going to get this after the new year. I want you to enjoy your holiday. Enjoy your family, enjoy your holiday. We're going to get this after the new year. So I'm like, hey, why are you talking? I got cancer. What are you talking about? And he just, it's that arrogant, confident type of doctor. I'm all for that. Because the fact that he was that confident / arrogant, but it calmed me down. And I was able to, kind of regroup. He said, hey, I do want to see you to talk through, some options. But I did exactly what he said, I was able to just relax, get myself together, have a great Thanksgiving, and then circle back with Dr. Allen, the following week. So when I did go back into the office, we chatted about the biopsy, obviously. Those 12 samples, 6 of 12 were cancerous. And they were all over. They weren't in one area. They were all over the prostate. And so you have the conversation about treatment options. You know, Brother Dr. Kelvin Moses talked about that Gleason score. So I was very solidly in a 7, a Gleason 7. 48, PSA is in the 5 range. Brother Moses talked about in the 50s in that 6 range being high risk. I was 48, late 40s, and in the 5 for PSA with a Gleason 7. Okay, so there's some concern there. So we talked about treatment options. Dr. Allen went through the variety of options that are out there. And some of them, Brother Dr. Kelvin Moses talked about just a few minutes ago. And then he gave me his recommendation. You know, he talked through the radiation, the chemo, all that. And he said, Derek, the radical prostatectomy, that will give you the longest chance for life, meaning you're not going to have a reoccurrence, or very unlikely to have a reoccurrence of prostate cancer. If you remove that prostate via that radical prostatectomy, that will give you longest possibility that, or longevity and kind of peace of mind because of my age. You know, if I were older, probably wouldn't have been the approach that I've taken. I was 48 years old, and he talked to me about that. And there's, you know, again, he talked to me about the other options. But what he said, and any doctor worth their weight, you know, he said, hey, Derek, I urge you to go out and get a second opinion. And said maybe even a third opinion. Well, I went out and got a second and third opinion. And I went to networks that were not aligned with, you know, my doctor. The second and third opinions, everyone was pretty much in sync with Dr. Allen's recommendation of the radical perspective. So we circle back, got my second and third opinions. But there's, you know, you take that approach, there's some things you got to consider. We talked about that. And at the end of the day, you know, the decision didn't change because you had these other options. But again, this is the option that statistically will give you maybe little longer longevity, and that, you know, not looking over your back to see if this cancer is going to come back on you. So we scheduled that prostatectomy for the 3rd week in January of the new year. This is what I call the aftermath, because up until this point, it's been lab work, the biopsy, conversations. Little did I know what was ahead of me. I just didn't know. Because you know, all you know is you want this cancer dealt with. That's it. You want this cancer dealt with. Because when you hear cancer, you think death. Probably normal to think that, but you quickly realize, hey, yeah, I got cancer, but yeah, I'm gonna fight. I'm gonna beat this, and that's the attitude you want. So I go into surgery, and about a 3-hour surgery. I'm in the hospital 2 nights. And again, I'm calling this the aftermath, because this is where I feel like you went to hell and back. Surgery was successful. I was completely out of it, woke up, and was able to have some conversation with Dr. Allen, and stayed a couple of nights till I was ready to be released. And, you're lying in bed, you're getting pain meds, you're not moving, so I didn't really know what was under the covers. I was in this bed and comatose, and you're gradually coming out of this. It wasn't until I was ready to be released. I think I had some sweats on, and you got your, I think you said to wear some baggy clothing or something, or, they told my wife at the time to bring some baggy clothing in. And I that's when I first realized, okay, I've got a urine bag attached to me. I've got a catheter in my penis, your manhood. That's the first, wasn't aware, didn't know. So I'm very thankful. It was a successful surgery. Very blessed. Now I'm on this road to recovery. And so I get home, and I've got this. This is a urine. This is my actual urine bag, and this is the catheter that was attached to my manhood inside my manhood. These are the straps that go to your leg, because when your prostate is removed, no control over your urine. I think Brother Moses talked about that a little bit. So 0 control. So that urine bag, got to empty it every so often, got to figure out how to sleep with it. It's a part of your clothing. Just something that, again, 48-year-old black male, great shape. I was in the gym all the time. Got a urine bag strapped to my leg, and a catheter in my manhood, and 0 control over my urine. Something so simple as how to have a bowel movement became a task. But not only that, I'd never ever in my life wanted to have a bowel movement so bad, for whatever reason. I think because of the pain meds, but I was on day 3 or day 4 without any bowel movement. Now, I think I called Dr. Allen. I was like, hey, is something going on here? And then it just finally came. But now you got this catheter in you. You're just trying to navigate all this. You're just figuring it out. You just figure it out as you go. So this catheter was in me for about a week. You got to remember, when it was inserted, I was asleep because I was in surgery. Well, they got to take it out, and I'm awake. So this has to come out of me in my manhood. I'm awake. There's no no sleeping. And Dr. Allen just said, look, Derek, Just 1, 2, 3 yank. And that's what happened. It was 1, 2, 3 yank, and I grabbed the side of the bed, but it was out. It was out, and I was done with the urine bag. Yeah, but there's always something around the corner, because after the urine bag came the Depends. So again, 48 black male in shape wearing diapers. Depends. Okay, so gotta wear them. Gotta wear them. There's no ifs, ands, or buts. You don't have control over your urine. You have to wear them. Started, working on some exercises, trying to strengthen, and eventually you do get out of the Depends. And you talking about going into a CVS or Walgreens or Target or Walmart, and you're picking up a box of male Depends. So get through that. It depends, maybe 2 weeks. Then Dr. Allen says, well, Derek, I'm going to recommend you wear a men's pad. What are you talking about? It's because I'm starting to go back to work. You wear business casual, your slacks. So it's the point where I had some control, but not all control. So if you were to laugh, you might get a squirt. If you were to pass gas, you might get a squirt. You had control, but not total control. So my urologist, he's like, hey, Derek, I think you're gonna need to wear men's pad for a little bit. Well, this is what I didn't even know these existed. This is what a men's pad is, which looks like a woman's pad. Well, this is a men's pad. Never knew these things existed. So if you're wearing slacks, let's just say I had some beige slacks on, and I was laughing with buddies or whatever, or there's a chance you could get that squirt, and you just don't have control, and now you got a big spot in the front of your pants. That's kind of what this is meant to do, to get at that. And that's like, look, I'm not wearing this. I did it for a little bit. I said, I'll roll the dice. I'll wear dark color slacks. No, I can't. But let me stop and just say that throughout all this, the one thing that kept me going is that I'm vertical. I'm alive and I'm blessed. And I'm trying to figure out, never did I just say, why me? Good Lord, I'm just trying to figure out what's the message. So get through that. But I'm gonna back up a little bit. The one thing that, I thought even, just kind of coming out of the surgery and wearing the catheter and the Depends, but there's one very, very important piece that I wasn't aware of. I was grateful the surgery was a success, and I was starting my recovery. But guess what? I did not get the pathology report back. So, doctor, as great as I was feeling, until you get that pathology report back, meaning did that cancer spread to other organs, you can't exhale. You can't exhale. So I'm like, damn. I'm waiting on the pathology report because don't know. That becomes a game changer if that cancer spread outside prostate, other organs. Well, it came back and everything was great, actually. And then you exhale. And I smiled, actually, and I think I may have went to, celebrate. Short-lived, though. Short-lived. As with this whole journey, this aftermath, ups and downs, right? Just like the whole process. I got through all that, and I realized I didn't have any movement in my manhood. So, which I knew going down that road when Dr. Allen and I talked, that was going to be something I needed to address if I took that option, the option that gave you the longest life. You do that, but there's going to be some things you're going to have to deal with. That's a pretty big thing. So we sit and talk again. Derek, look, this is Dr. Allen. He said, Derek, essentially he said, I've got you. This is not going to be an issue. We're not talking about, Viagra. We're not talking about anything like that. I said, well, explain. What are you talking about? Because that's all I know. There's a way in which you can have excellent relations for people that have gone through this surgery, for men that have gone through the surgery. It's an injection. And so something I had to wrap my head around because, again, this is new, right? So that radical prostatectomy that I had, that will generate, you're not going to have any movement in your manhood for a minute. Well, sex is a big part of relationships. It's not everything, but it's important. I'm speaking from my standpoint. To each their own, but that's something that's big. And so Dr. Allen said, hey, this is what we're going to do. He's going to give me a script for this compound med. This med is made in a laboratory. This is not anything you can get at CVS, Walgreens. This is a med that is made in a compound laboratory for this specific purpose. It requires a diabetic needle. So here is your. Let me just show here. Okay, so this is a diabetic needle. Let me see here. Okay, all right. So this is a diabetic needle. Take off that cap. All right, and then you've got the syringe. This is what you have. Okay. You have the med that's in a laboratory, compound lab. A couple of cc's would be in. Let me see. Like this. Okay. And you would simply draw down on that. A couple of cc's, not much at all. So you got it in. You see the tip is drawn back. So now the cc's are in. And this goes to the side of your manhood. It's a prick. It's all tissue there, the side of your manhood. It's just really fatty tissue. So it's a prick that goes into the side of your manhood. And within 1 minute, their take, you are ready for relations in a big way. And you're ready for 90 minutes because this med is not driven by an orgasm, it's driven by time, meaning only time will subside. I say 9, give or take. Didn't know all this, and so I'm asking Dr. Allen, okay, so what happens? What happens? I'm saying, hey, what happens? Male talk. What's say? Well, Derek, he's like, well, you have no ejaculate, so there's no ejaculate, there's no sperm, all that's gone. Like okay. I said, well, it's orgasm. I mean, how does and he said it's something interesting. I can't answer that. And he said, Derek, I don't know. I can't answer that. He said, I can give you a number of one of my former patients that can. So you figure it out. Just by trial and error. So I figured out that there's no change. I'm speaking about the orgasm, the male orgasm. You can have a knee buckling orgasm that you've had prior to surgery, or that you're known, there's no change in the intensity of the orgasm. Well, what did change is you don't have the physical exertion of fluids that I talked about. So that was something that I had to wrap my head around through this journey, this aftermath. Being blessed that this cancer was caught, being blessed that I had the insurance coverage to take care of it, to get the surgery, all that, just being blessed. And just trying to figure out how to get back to normalcy. So, but it was easy, actually. You get the hang of it. It's actually, it's, that was fine. That was actually fine. At the end of the day, and you live life. You pick up your life, and my next steps, trying to figure out again. I just said, what is the good Lord asking of me? At that point, I knew that there were probably brothers going through this, or that have gone through this, or that are scared to go through this, or this. I was going to make this my mission to be an open book, because I did not, when Dr. Allen gave me a number of the guy to ask about orgasm, I was too scared to ask that guy. Embarrassed, scared, whatever. That's what I'm trying to get out and promote. It should never be that way. Should never be that way. There should never be any shaming game. So that is the passion I have for this illness, that is so very much treatable in our Black community, but that kills so many Black men. I know good educated brothers that haven't been screened and they're 50 plus. This cancer will surely take your life. You take it for granted. Early detection saved my life. I was getting screened at 40. The Gleason 7. Yeah, this was probably, if I wasn't getting screened, if I just ignored, getting that annual exam, yeah, I think Brother Moses would agree. I would not be here talking to you guys. So that's my blessing. All that other stuff I talked about, I didn't know at the time. I was just finding my way through it. But that aftermath, it was hell. It was hell. But I'm here. Giving my testimony. But we got so much work to do. And whether it's all of us or the fraternity or the D9, this is our, what's going to happen next week, October 1st or Saturday or this weekend? You're going to see pink everywhere. You're going to see pink awareness everywhere, as there should be, breast cancer. But we've got to get some visibility around prostate cancer awareness and that baby blue ribbon. And I think if we do that, if we start to push that needle, save some more lives. But I will end with this. No brother walks alone. This is my motto. No brother walks alone. No brother fights alone. And no brother should suffer alone. And I'm sure that's happening out there, but that should not happen. So that is my journey, my aftermath. Tried to be as candid and frank and upfront as possible, given the audience. 54 years old and just blessed to continue to be able to message. And Dr. Moses, he and I have done this a couple of different times. I could talk all day, any day to anyone if I can save one. Brother Greg, I will end with that.
Brother Williams, thank you so much for your transparency and your testimony. Brother, I know we've helped some brothers and some sisters tonight. So thank you so much, brother. Thank you for sharing. We do have some questions that we want to get to. And it seems like a reoccurring question is prevention. What can we do to prevent this? Brother Dr. Moses?
I don't know if there's a great answer to that question or not. And I hate to say that, but when you think about prostate cancer and even breast cancer, those are both hormonally driven cancers. There are also cancers that respond to stress and inflammation. So what I would say for any cancer prevention are do the things that you've heard all along. That's avoiding tobacco, that's limiting alcohol. It's also about reducing stress. It's about exercise. It's about healthy diet, avoiding processed foods, and really doing all the things that we've been told our whole lives, or at least we've heard. But really, it's about that. As far as preventing cancer, there have been some studies that have shown that some men with diabetes who take metformin are less likely to develop cancer. And there have been some large studies showing lower cancer rates in people who take metformin, but not everybody can take that because not everybody has diabetes. There are other medications that have been used for urinary function where there was a lower rate of prostate cancer, or at least slower rate of growth of low-grade prostate cancer. But again, not everybody needs to be on those. So what I would say is adopt a healthy lifestyle, healthy diet, exercise, drink plenty of water, and mindfulness. Get that stress level down as much as possible.
Awesome. Thank you. Now, Brother Williams, we sit through cowboy games, we sit through movies and all of those kind of things. But when it comes to sitting through and listening and hearing about prostate cancer, we get a little squeamish. What advice would you give some of our guests tonight on sticking with it, hanging in there? I heard in your testimony, what it took for you. What advice would you give just for some brothers who are out there who maybe are afraid to have the test, or maybe just got some results back?
Yeah, great question, Brother Greg. And it's your health is your wealth. I mean, your health is your wealth, and you want to be in a position where be around for your family as long as you can, and so being proactive, is educating yourself as well. It's reaching out to your resources, your networks. That's something that would love to be able to see as we can somehow have a more formalized network or outreach or support network, whether it's within our frat or and there are some that are out there. I even looked. I think we can probably do some things, and that's kind of my vision. Probably easier said than done, but I just think that being proactive. Sure, I think you could have someone that may be hesitant or maybe a little scared. It's because they just don't know. And I think, by reaching out to maybe people that have gone through that walk would kind of ease that mind. But remember I said, about, suffering alone. That's so important. We don't want our brothers to suffer alone. Suffering alone can be you feeling like, man, I don't know if I want to do this. And as brothers, we sometimes, internalize. I mean, we keep things close to the chest, and what things that may not really worry, or things that are worrying us, we may not really let your spouse or someone know, and can't do that. So that's just my advice, Brother Greg.
Awesome, thank you, Brother Dr. Moses. We got a question about why are Black men so much more at risk for prostate cancer than our white counterparts?
I think a lot of factors play into that. So there is a genetic component, and as I told you, Black men in the U.S. have the highest incidence compared to Caribbean Black men and Black men in Western Africa. I have a suspicion that a lot of it does have to do with stress and inflammation. I think it has to do with living in a society where we are, in an oppressed state, right? So we have to deal with societal pressures, and that's why it's not just prostate cancer. It's controlling hypertension, it's controlling diabetes, and women it's in controlling breast cancer. It's sort of a similar picture. Diet and environment do play a role. And this has been studied in Japanese men. In Japan, men have a very low rate of prostate cancer. Japanese immigrants have a higher rate, and then the children of those immigrants have an even higher rate. So there is something that is dietary and environmental that plays a role. But we can get equivalent outcomes compared to white men, even if diagnosed at a higher rate or higher incidence. In an equal access system, you can get equivalent survival outcomes. And this has been shown in the Veterans Administration, where any man who served in the military has access to healthcare, and they typically get very good outcomes, if not totally equivalent, close to it in Black men. So that's why it's important to get that early screening, get that education, and if needed, get the treatment that's necessary.
Awesome. And I think one last question I'm going to pose it to both of you, and I want you to think about an answer from your perspective. And we've got a lot of guests on here tonight, and well, people want to know. We hear a lot of information about supporting breast cancer survivors or other types of cancer survivors. What would you say are some tips or things that families, spouses can do to support a brother that's going through this journey, like Brother Williams talked about earlier?
I'll start that off and kick it to Brother Moses. I mean, I think just being there, right? Being that partner, but also you're gonna have to give some space, because that brother, he's going to be going through something, and so it's just that balance, right, of being there but knowing when to give some space, and just making sure that it's still the same person. There's some subtle changes, but usually that you can work through that, Brother Greg, and but I think it just requires patience. I think it requires some understanding of the illness, so that spouse should probably take it upon herself to maybe get up to speed on some things, and just so understand what the person might be going through. So that's kind of what I would say.
Good, thank you, Dr.
Yeah,
Moses.
I completely agree. It's for most men, it's pretty natural to kind of internalize, right? We consider ourselves caretakers and the strong silent type and all that. And so it's very easy to get in your mind and get that tunnel vision that I mentioned before. And I agree with Brother Williams, let that man know you're there. Hey, you want to talk about it? Cool, let's talk about it. You don't want to talk about it? Cool, let's chop it up about something else. But let them know that they don't have to go through this alone. And that's why I put at the end of my talk some of the resources where there's support groups, there's FIN, Prostate Health Education Network, there's Us Too, there's Zero, there's Prostate Cancer Coalition. Sometimes you got to get around other men who have been through it or are going through it, just so you're not going through this alone. You're not the first person to do it. You're not dealing with the worst. Like sometimes, it's called commiserating, right? Like sometimes you just have to hear it from somebody else, even if it's the exact same thing. Now you have something that you can share and bond over and discuss. And I think that's really important for mental health.
Yeah. Real quick, Brother Greg, that, Brother Moses spot on. And, again, I look back on that. I was, I didn't want to ask that question to that guy. I didn't know him. And this is about education. Like we can't, we can't do that. We've got to understand this illness, not be afraid to ask anything, everything. I mean, that's something that we've got to get better at.
Well, brothers, I tell you, this has been so enlightening. The comments that we've gotten, and thank you to our guests for your comments and your questions that you put in the chat. And Brother Williams, thank you again. Brother Dr. Moses, thank you again. We talked as we were preparing for this. We wanted to provide more than just a medical perspective. We wanted to provide a full perspective from all sides. And so one of the things that we did discuss with Brother Williams was, would he share his contact information? So if there are brothers out there, if there anybody who is out there who would want to ask questions or spend a little bit more time with Brother Williams and learn more, and Brother Williams is open to it. So we're going to put his contact information out there. If you want to know more, and I know one of the questions that we had was talking about how long does it take to get back to normal life, and so we're prepared to wrap up. I'm gonna let you have the last word, Brother Williams, and then we're gonna close this out with some information.
Wait, what do you mean normal life? So you can,
That's what the question was. I think he meant back to where you are, as you talked about in your journey, where you are now in your journey.
Yeah, and so it's a good question. A lot of bros are going through this. Okay, let me see here. That's a great question. So I feel as though, I'm 6 years into this. Man, I would say probably year 3 or 4 is when year 3 or 4 is when I was like, okay, this is, I'm good, but if you're talking about, it depends, because I can speculate maybe where you're going. I'm not sure because I'm not able to ask any questions. But I would say back to normal, I would say 3 or 4 years. Everyone's going to be different in terms of their rehab with what happens with your manhood, and that varies from person to person. So I'm not sure if that's where you're going. But if you're just talking about the day-to-day, just getting through it, and what I call that aftermath. Yeah, year 3, you're probably through the worst of it, and you're just in a good spirit. You're good, but you're again only because you're still going to see the urologist and you're still getting PSA blood work done, and you want to see it to be undetectable. You still kind of tense up every time you go to your urologist and get that PSA, and mine come back now undetectable, and that's what you want, but you still tense up. Anytime I go to any lab, I'm tense now. Like whether it's my primary care, any lab report I get, like I'm tense right now because I'm a cancer survivor. Like, so, I guess that's how I would answer, Brother Greg.
Here's what we're gonna do. We're gonna put your contact information, and we'll individuals can contact you. But we want to give our audience, and we want to again thank our guests for being here. Thank you for again your comments, your chats. We want to thank you for being here. We want to give you a little time tonight just to reflect on the conversation, and also a little bit more time to check out the All of Us research program, to scan your QR code to complete that post survey. If you didn't get a chance, that post survey link, which is on the screen now, take a second. Think about what you've heard tonight. It's programs like this that we were able to provide with the resources of the All of Us research program, as well as Alpha Phi Alpha and Zata Lambda chapter. But it's programs like this, and I'm just going to encourage you, as one who has been a part of this, to take that next step. Go to www.joinallofus.together.com and check out All of Us research program. Click on the link, learn more about it, learn more about precision medicine, learn more about all that we are as an organization are trying to get the information out. And we're grateful to be able here to be with you tonight. We're glad that you were here. Thank you so much for letting us know how we did. And I'm going to be quiet for a second and let you ponder as you go on and click on that, scan that post survey link. And again, if we can get Brother Williams' contact information that we can share, and we can put that on the screen if we can get that up for anyone who has any additional questions. Brother Williams will be more than happy to discuss and to share with you. Again, thank you so much for being with us tonight. On behalf of the All of Us Research Program, on behalf of Alpha Phi Alpha Fraternity Incorporated, on behalf of the Zata Lambda chapter of Alpha Phi Alpha, we say thank you. Thank you for joining us. Thank you for engaging with us tonight. And thank you for participating in our pre-survey and post-survey links and checking out the All of Us research program. So look forward to more programming coming out from our other organizations in the BGLC. And again, thank you for being here tonight. Hope you all had a great evening, and continue to post chats. If you have other questions, you may continue to post them in the chat, as well as we did have Brother Williams' information up. So without anything else said, any further ado, have a great night. And remember, your health is your wealth. You can do this. Thank you.